this happens to be a passionate topic for me. That is bicuspid aortic valve associated disease, and I've been tasked today to talk specifically about SAVR, I never shy away from a moment to be provocative, and hopefully that I will be provocative in this regard with respect to the role of surgery, specifically in the context of bicuspid aortic valve disease. I don't have any financial disclosures. I do serve on a medical advisory board for Abbott, but I take no monetary remuneration for that work. So I would be remiss if I didn't spend a little time talking about this man, just simply because of how precocious he was in identifying this problem as an entity that leads to death, and that's Leonardo da Vinci. Some 540 years ago, he was the one who we credit with first discovering that this was in fact a problem, and from there, many hundreds of years passed before we gained more insight to such that we have now. But we now all know that this is an hereditary disease. So there's Leonardo. So I won't spend any more time talking about Leonardo. But in any case, we now know this is a hereditary disease, commonly presenting in the 4th to 6th decades of life, more common in males than females. One of the striking points of note is that this part of the heart, the aortic valve, the aortic root, stems from neural crest cells, different than other parts of the heart. That has some relevance that I don't have time to go into now, but it does bear some relevance even to this topic. The one thing that I think is interesting about bicuspid aortic valve associated disease is that we traditionally haven't been calling it a syndrome, but in my opinion, it is. These are the three predominant components: valvular disease, aortopathy, and coarctation. Not every patient having coarctation, but every single bicuspid patient having some form of aortopathy, and certainly valve disease, presenting either as stenosis or regurgitation. The other phenomenon that has been well recognized now for over 2 decades is that there is a progression to the velocities across bicuspid valves, and there's a progression of aortic dilatation over time, and that's at multiple levels. We know that all of us, everyone on this call, all of our aortas are growing, are expanding over time, and that's the dark blue line. But the bicuspid population expands at a faster rate over time, and that bears some relevance to this specific discussion of choosing SAVR over TAVR or vice versa. The bicuspid disease, as everyone knows on this call, of course, comes in many forms and many shapes and sizes, and we're going to talk about some of that. What's interesting is there's been a fair amount of debate on establishing a nomenclature. I think some of this debate is somewhat silly because most groups around the world do adopt the use of the Sievers classification system that he first described in 2007. I think this is a good system. I don't see a whole lot of value of expanding beyond it because it's a language we all certainly can understand. But that said, there have been many others who've described various, suggested various nomenclature schema, but I would suggest that we kind of end that discussion and just move on. I think we all recognize what we're talking about. Here's a recent paper just published this year suggesting even a newer nomenclature schema designed for TAVR, but nonetheless, I think probably just as well to keep using the Sievers classification. This is a classic paper that Marty Keene, the Penn Group, wrote back in, now it's been 2 decades ago, and it underscores this is comparing a bicuspid population to a referent age and sex matched control group, and just demonstrating that uniformly patients with bicuspid aortic valve have larger diameter sinus segments, STJ, and proximal aortas compared to referent age and sex matched controls. That becomes relevant when we're managing these from a surgical standpoint. There has also been a fair amount of discussion and study about what the relative impact of aortic disease to valvular disease, and the truth of the matter is it's difficult to really tease out, whether or not it's distinctly important that one be treated over the other at a distinct time point, because we're not always comparing apples to apples. That said, there's been a lot of papers written on this point, and and generally demonstrated that they are similar. What's also intriguing of more recent data is that if we take a matched population of bicuspids and tricuspids with aortic stenosis and look at their aortic event their aortic event-free rates are pretty similar until you start to get out, beyond 10 years. It's also true that for bicuspid populations, and this is a New York data set, but there are several others that have reproduced this. But the reality is, among the bicuspid population, of those that are bicuspid, that are within the healthcare system, they're getting surveilled, they're getting treated appropriately, they will have a normal life expectancy. And unlike some other cardiovascular diseases, the point of that is really that this is largely a surgical disease that can be cured, and patients can be put back on their normal life table. While it is true that all of these patients, the majority of patients with bicuspid aortic valve do develop aortic dilatation and ultimately will develop an aneurysm, the rate of dissection among the bicuspid population is actually very small. And we could spend some time perhaps at the end talking a little about that, but I want to get to the root of the matter, talk about the valve disease. We can see that this is again a set of 600 plus patients this is from the Mayo Clinic, bicuspid patients that have been followed prospectively compared to a referent group. And you see again that they have the same survival over time as their age and sex matched controls with the general population. Another fact worth noting as we start to nuance the decision making about valve replacement, the aorta in these patients continues to dilate. If we don't treat the aorta up front, they will continue to dilate. What impact that has? Well, that depends on the size at the time of treatment. Here's a frequently quoted study where separating patients out. This is patients that have bicuspid disease that just underwent aortic valve replacement, and depending on their aortic diameter at the time of valve replacement dictates their outcome and their freedom from aortic event at the 10-year mark. And they're distinctly different depending on the size of the aorta at the time of the valve replacement. It's also true that patients with bicuspid aortic valve stenosis compared to tricuspid, they have a better survival. And this is unmatched data, of course, and a lot of that has to do with the fact that bicuspid patients present with stenosis at a much younger age. They're younger and healthier than patients with tricuspid aortic valve stenosis. That said, even when we matched, this is a matched population, and you can see even with age-matched populations, comparing bi and tricuspid valve stenosis, you see that the bicuspid population does better. I think that's also relevant, and hopefully I'll kind of get you to my punchline here at the end. The incidence of late aortic events is also slightly different, with more aortic events in the bicuspid population compared to the tri, which we would expect based on what we all know about the aortopathy. Similar to the nomenclature for the valve itself, there's been many papers trying to categorize and place patients with bicuspid aortic valve into a certain aortic shape. That said, there's been no consensus on establishing a nosology for bicuspid aortopathy itself. What's also striking, and this is a recent paper, and I'm going to tend to use this often in my future talks. This is one of the few papers that tracks aortic caliber over time, comparing bicuspid. These are patients with aortic stenosis, bicuspid aortic valve, and tricuspid, and you see remarkably that there really is not distinctly increased risk of progressive dilatation in the bicuspid over time compared to the tri, at least out to about 10 years. Getting to the discussion about strategy for valve treatment in the context of stenosis in the bicuspid population, I start with the NOTION trial. This is not bicuspids, this is just low risk patients, but you can see equivalency at least in the midterm outcomes between TAVR and SAVR. And we start to, and there's the momentum in favor of TAVR is really predicated on this early term and midterm survival curves, suggesting if TAVR performs as well as SAVR, then why would we want to do SAVR? And I got to tell you, I would argue that we're really missing the point if we're going to limit the discussion to this early, and I'm calling even out to 8 years, early term mortality differences, as we've now been able to prove there really isn't any. When we compare, this is another paper published a few years earlier than that, so perhaps more of the early years within the TAVR experience, you see a mortality benefit. These are low risk patients in favor of SAVR, but it's small, and the curves, as you can see, don't start to diverge till we hit the 3-year mark. But I really think that the focus on the discussion has to go well beyond that and is more nuanced, and it revolves around really 2 points: that of durability and that of hemodynamic impact. And I hope to spend a few minutes on both of those points. And I highlight this part of this meta-analysis. I highlight the fact, and this was already brought up, about this issue of paravalvular leak and what's the impact of paravalvular leak over time. And we know there's a lot of data now suggesting that paravalvular leak in the context of TAVR can be a bad thing and portend an increased risk of mortality. There's many papers. I'm just showing 5 or 6 of them now. You can see that if there's any significant degree of moderate or more, especially paravalvular leak, that portends a survival loss over time, and particularly in the context of TAVR. And I think this is relevant. The other thing that I think that really to date has not seen a lot of discussion, and that is, what is the impact of these valves on the aorta and also on the heart over time? And here this is some data from my own lab looking at wall stress in the context of a bicuspid valve and what impact it has on the aortic wall. This is so-called time-resolved phase contrast MRI, and there's been a lot of work in this space as well, looking at flow dynamics, blood flow dynamics across the aortic valve in the context of a bicuspid valve compared to a normal tricuspid valve. And these patterns of these turbulent blood flow patterns vary depending on even the morphotype that we're talking about. And here, this is a really, really important paper. If you wrote anything down, you might take a look at this paper published in the Journal of Cardiovascular MRI in 2018. This looked at patients with bicuspid valve compared to tri, and then post different forms of valve replacement strategies: mechanical AVR, stented bioprosthesis, of which, of course, all TAVRs are stented bioprostheses, and the Ross procedure. And they have marked differences in the flow characteristics across that, and what type of wall shear stress would be impacted based on the valve type implanted. And if we look at ascending aortic flow patterns in the context of these different types of valves, we can see healthy volunteers have normal helical blood flow, whereas the bicuspid has markedly abnormal helical blood flow pattern, and so do all bioprosthetic valves over here on the left. But strikingly, you'll note that the blood flow patterns are much more normalized in the context of a mechanical valve or a Ross procedure than they are any bioprosthesis. This is reflective of the stent frame within which these valves sit. And if we look at mean rotational flow, again, look, this is the bicuspid valve here on the far left. These are bioprosthesis, the second bar. And if we look at Ross and mechanicals compared to healthy volunteers, we see much closer to normal rotational flow pattern through a Ross, an pulmonary autograft, or a mechanical valve. Again, this is depicting the same thing, just demonstrating a statistically significant difference in mean rotational flow in the context of aortic stenosis, bicuspid compared to a bioprosthesis compared to a mechanical prosthesis. So the impact of these flow dynamic differences is seen here. This is a presentation that Danny Demir made at EuroPCR in 2016, highlighting the structural deterioration we see in these TAVR valves. And really why we see this is reflective of these flow dynamic issues that I'm trying to illustrate. Remarkably, when we study differences between, say, bovine and porcine stented valves, we can't see a whole lot of difference. And I would put all TAVR valves in this same category, where not being different from a hemodynamic standpoint of either the porcine or the bovine surgical valve. This is a very recent paper out of some of my former colleagues at the Brigham, and it demonstrates what the structural valve deterioration rate is for bioprosthesis in younger patients, those less than 65. And I think this is distinctly important for the bicuspid population, because most of these bicuspid aortic valves that we're talking about treating, either by SAVR or TAVR, are in patients that are younger than 65. And you can see, if we look at the subclinical defined by not reaching the need for valve replacement, the rate is about 75% at 10 years, with a clinical structural valvular deterioration at 10 years about 30%. These are real numbers, and I'll speak to why I think that's relevant for the bicuspid population. This is Joe Wu's paper published in the New England Journal in 2017, just highlighting a survival advantage for the mechanical valve in the aortic position over a bioprosthesis over time. And that survival advantage really isn't seen until you pass the 8-year mark. But then you see that the survival curves start to diverge. I think this is not relevant for patients that are elderly, because it becomes a moot point. If they only have a 10 to 15 year survival, then that certainly becomes moot. But for the bicuspid population, many of whom have a 30 to 40 year predicted survival after their point of treatment, this becomes distinctly relevant. Here's some more data suggesting that the mechanical valve has a survival advantage over the bioprosthetic valve beyond the 10-year mark. And again, this is additional data looking at cumulative survival, showing a difference in favor of a mechanical valve. This is New York State data showing the same thing, a slight advantage over mechanical compared to bioprosthesis after the 10-year mark. This shows the marked difference at the 10-year mark of incidence of reoperation in the bioprosthetic arm compared to the mechanical. Again, and similarly, the marked structural valvular deterioration rate in the bioprosthetic at 10 years compared to the mechanical. So the mechanical valve offering a hemodynamic benefit that I think I've shown, as well as a durability. There is now discussions are mounting about what other options for anticoagulation. And there, as I'm sure everyone knows, there's an ongoing now clinical trial with the Onyx valve comparing NOAC to Coumadin beyond the 3-month mark, and we're all anxiously awaiting the results of that trial. That's the so-called PROACT 10A trial that is ongoing and accruing patients as we speak. I did want to spend a few minutes on the Ross procedure, because I think this is an underutilized operation in the context of bicuspid disease. There are several groups around the country that have embraced it. This is data from Will Ryan's group down in Texas. He's been promoting the use of the Ross in the bicuspid population for many years, and this is his series and shows excellent results over time. This is Von Starn's series in bicuspid patients, and it just comparing different bicuspid morphotypes, the LR versus the RN, the more common, and there may be some distinct differences in outcome with the Ross procedure depending on morphotype. So that there's also some debate about what type of Ross procedure, using the full root or the inclusion technique in the context of bicuspid, and perhaps we can, if we have some time at the end, we can talk about that. And this is again data from Von Starn's group. Just again, these are all bicuspid patients, and looking at autograft reintervention rates over time in the context of bicuspid aortic valve stenosis, using or not using an autograft wrap. I'm getting close to wrapping up. The other point worth mentioning is just the cost differences comparing surgery versus TAVR. They still remain in favor of SAVR over TAVR, roughly double the cost in lower risk patients. Higher risk, it starts to become, the expenses start to go up for all cardiovascular disease. But if you compare these lower risk bicuspid patients, for example, it's roughly double the cost for a TAVR strategy over a SAVR. So in conclusion, I would not want to debate the point that TAVR is feasible, safe, demonstrating early and midterm results that are equivalent. I think the jury has concluded on that point, and there's little debate that TAVR is safe in this population. I think we're missing the mark, though, if in thinking that is the discussion. I think the discussion needs to move beyond that and talk about much longer durability issues and the hemodynamic impact of the different valve types on both the heart and on the aorta. Bioprosthetic failure prevalence is abounding, and this is in the context of now known recognition that there is a mortality benefit, particularly in these younger patients with a mechanical valve strategy. And I would close with just the provocative statement: what are the implications of using TAVR in bicuspid patients that have a 30 to 40 year life expectancy? I think it's at least unclear at this point, and taking on an aggressive TAVR posture may be misguided.